Welcome, everyone. The Association for Professionals in Infection Control and Epidemiology is pleased to present a live from industry webinar. Today's session is titled The Identification of an Endgame of False Positive, CLABSI. Today's Please note today's presentation is being recorded and all participant lines are muted. If you need technical assistance at any time, please send us a message in the chat box or send an email to elearning@apic.org. Today's presentation will last up to 60 minutes and includes a question and answer period. Your questions will be addressed at the end of the session during the designated Q&A session. APIC and our corporate partners work together towards APIC's mission to create a safer world through the prevention of infection. We are pleased to offer today's webinar as a part of our Live from Industry program, where APIC corporate sponsors share their expertise on a range of topics relating to infection prevention and control. Our corporate partners serve a vital role in the work APIC does to advance patient safety. APIC would like to thank our program sponsor today, Magnolia Medical Technologies. As healthcare providers, we are on a mission to zero. The goal for all healthcare institutions is to be a high reliability organization, and the only acceptable number for patient harm is zero. I'd like to introduce today's speakers, Barb DeBron, a nurse with over 40 years of experience in the field of infection prevention and quality improvement. She's currently the improvement advisor with Source Health. Tammy Johnson is a nurse with over 30 years experience and 20 years as a nurse leader and executive in medical device industry. She is currently the Associate Vice President of Clinical Strategy and Customer Relations with Magnolia Medical Technologies. Welcome to the Magnolia Medical Technologies team. The floor is yours. You're currently muted, so you might want to unmute to begin.
Can you confirm that you can hear me?
Yes, we can hear you.
I'm sorry. I don't know. I must have been. I got so excited. I must have pressed the wrong button. So let me reboot here. I am delighted to be here today. We've got a lot to cover. Our primary objectives are to really shine a light on the role that contaminated blood cultures can have with the impact that it has on CLABSI. Tammy and I are going to spend a little bit of time giving some background information about CLABSI and kind of meet us where we are at the moment. But the ideal discussion today is to elevate the importance of how our blood culture collection can impact our interpretation of our central line infections or lack thereof. So we didn't want to start this presentation without an acknowledgement that we have been just kind of sucker punched. For those of us that work in the field of infection prevention, have had one heck of a couple of years, and it would be crazy for me not to at least acknowledge the fact that COVID-19 has had a profound impact on everything that we do, in particular CLABSI. And I've put a couple of photos in this slide just to kind of showcase, I think, kind of where we're at. But as an infection preventionist, the unconventional practices, doing the unimaginable, things like providing places for staff to hang their little bags so that they could save their personal protective equipment to use over and over and over again. Things that were just previously, are things that we would include in our little shop of horrors, were things that we were doing because we really had no other options. And then we also know that in many situations we had nurses pulling IV pumps out into the hallways, and a lot of this was to minimize the need to actually garb up and go into these patients' rooms who had COVID. But because of this, we know that there were some, again, unconventional things such as running long extension tubes that enabled the nurses to monitor the patient without going in the room, when I rounded in many hospitals that I did some work in, I just kind of cringed when I would see some of the practices like IV tubing resting on floors. And we also know that we treated our patients differently, especially the COVID patients, by turning them on their bellies. And we just wonder how all the things that we did have profoundly impacted our progress. So I wanted to just set the stage for Tammy and I to be able to tell this story and start a little bit about what we've traditionally done in the past to reduce the risk of CLABSI. So this slide illustrates the 4 primary buckets, and much of it is attention to applying bundles. Bundles are processes and practices that are packaged together because science has shown us that if we do things together, we have better outcomes. And so part of it is related to the insertion piece, where it's all about using the right technique for the insertion of the central lines. And then, of course, the maintenance bundle is related to how we care for the patient once the central line is in place, everything from potential CHG treatments to the dressings and all the other things that are related to care. And then, of course, there's the other bucket, which is having specialized teams, whether it's a vascular access team or a PIC team. We also know that nurse-patient ratios have an impact on CLABSI outcomes. And then the next piece is really around rounding and auditing and just having focus and using checklists to make sure that we're doing the things that we believe that we're doing. And then this slide just kind of further breaks things into different bundles, which is kind of comparing the individual and groups and how they conform with the normal practices and the values. And then on the right side of the screen are the bundle elements, the things such as maximal barrier protection and site selection and using observers and port cleaning and all these other things that are related to improving CLABSI or reducing the risk. So what happened as a result of this? So we actually got a lot better. We know that application of these bundles has had a really profound difference. We were seeing lots of improvements. Much of it was really related to the use of checklists. And, we know checklists are like shopping lists when you go shopping. If you have a checklist and you follow it and you check and you make sure that we're doing the things that we should be doing, then we know that we have a more reliable process, and we have a more reliable process where we're doing standard work. So we did see a significant improvement in CLABSIs between 2008 and 2016, about a 44% reduction. And then we saw an additional reduction from 2018 to 2019 with another 7%. So I think for those of us that work in this field, we know that we still weren't doing great, but we had a significant improvement. And so then what happened is the world stopped spinning. We know that we were making a lot of progress and seeing a lot of improvement, and then COVID hit. And COVID has impacted everything that we do. So just to reframe this and to make sure that we all are clear on this is that we've always had a requirement to get better. We know that even though we were making improvements, that the 2020 target, and this was, had we had a crystal ball and knew that COVID was going to rock our worlds, maybe it would have been less aggressive. But we know that our 2020 target from 2015 baseline was the expectation was that we reduce our healthcare-associated infections between 25 and 50%, but for CLABSI it was 50%. So we knew that we still had a lot of work to do. So despite the fact that we had insertion bundles, maintenance bundles, and lots of other practices, we still knew that we had a lot of work to do. So this is a kind of a sobering piece of data, and I'm sure many of you have seen this and have probably shared this with your teammates. But this is just this showcases and demonstrates how healthcare-associated infections just went way, way, way up in 2020. Year-over-year increase in CLABSIs in the second quarter, 28% increase, and then in the third and fourth quarters of 2020 compared to the year before, close to a 50% increase. And I wanted to just take a moment and acknowledge a quote from Anne Marie Pettis, who is our current APIC president, who I'm sure many of you know and love. And she was interviewed, and one of the comments that she made, and I'm just going to quote her, is that the unfortunate reality is that in 1 year, we lost nearly a decade of progress against HAIs, such as central line-associated infections, catheter-associated UTIs, methicillin-resistant Staph aureus, and ventilator-associated events. And Anne-Marie, I could not agree with you more. And it is a pretty big buzzkill. It's really hard to think that we have lost so much progress. However, I am quite optimistic that we can get ourselves back on track. And just in case that data wasn't sobering enough, I mean, this is like mind-blowing. This was a recent publication in Itchy that came out of the greater Detroit area, where they saw that they had a 325% increase in CLABSIs. In addition, an 18% blood culture contamination increase. So I know every time I receive my Itchy journal or my AJIC, I take it out of the plastic and I look at the table of contents, and I know that over time we're going to be seeing more and more data coming out that is going to underscore and validate the fact that we are, that COVID has had such an incredible impact on us, and it really puts Anne-Marie's comment in true perspective. So what I'm going to do is I'm going to turn the conversation over to Tammy, who's going to walk us through kind of the purpose of blood cultures and what do we mean by blood culture contamination. So Tammy, take it away.
Thanks so much, Barb, for that great. Thanks so much, Barb, for that great recap. And we thought it may be helpful to just look at the purpose of blood cultures, right, and the true definition of contamination. And if you already feel confident in this information, then take a quick power nap. I'm sure it's well-deserved and earned. And we thank you again just for all that you're doing for healthcare. And we couldn't say really thank you enough for who you are and that you're just staying true to your craft and your expertise in what has been a really difficult time for us. So just wanted to extend that huge debt of gratitude to each one of you. When we look at the purpose of blood cultures, it really has three main aims for us. We really want to see if there's an infectious etiology in our patient, and then to be able to identify that etiological agent, right, and let that guide our antimicrobial therapy so that we can de-escalate and we can target therapy. And that's really our big aim with antimicrobial stewardship. So as we look to the definition of blood culture contamination, it's really defined as the recovery of normal skin flora, what we call common commensal organisms, from a single blood culture. So when we look at blood culture and what that really is defined as, it's a specimen of blood submitted for bacterial or fungal culture, but it's irrespective of the number of bottles or tubes into which the specimen is divided. So there's no giving one stick and filling 4 bottles and calling that 2 sets. That's a huge no-no for us because we can transfer organisms across those 4 bottles, and something can be represented as a true bacteremia in that case when it really was a contamination. So when we look at blood culture contamination rate, that represents our common commensal organism occurrence in one set of blood cultures. And again, that set of cultures, it's the blood culture bottles or tubes into which a single specimen of blood is inoculated. And we look at required volume and assume that that is there so that we can accurately detect what is in the patient's bloodstream. And it's kind of what I call the Goldilocks principle. If we put too little into the blood culture bottles, we're not going to have organism capture for micro to grow out. And if we put too much, that can actually alert us as a false positive because we have things gassing off and turning that tube acid or that bottle acid and saying there's growth in that when there really isn't. So just a quick recap there for you. And then again, the identity of the organism. When Bates did his study, he found that the identity of the organism was the most important predictor in predictive model differentiating contaminated blood cultures from what was truly a true bacteremia. And you can see here our common commensal organisms in this list that are our probable contaminants. These are our usual suspects. And the one you see there, coag-negative staph, is the most predominant contaminator for us. But these organisms should be considered contaminants unless they're recovered from multiple blood cultures obtained in sequence, and that's within a 24-hour period. And in that case, We have to make careful assessment of the patient and additional laboratory information just so that we know that we're getting this right. And that's a great quote by Dr. Gary Dorn there. When we look at the identity of the organism that is usually a true bacteremia, these are typically our non-common commensal organisms. And you can see here, these should not really be on the skin. We shouldn't be picking these up, but we'll dive into this later of really what's creating these false positive CLABSIs for us. So any organism not found on the NHSN common commensal list is considered a recognized pathogen for NHSN reporting purposes. So let's just dive into a little bit more of this and completely confuse you here for a moment. So what happens here is that our common commensal contaminators can actually be pathogens, as you well know. And you can see here from this study by Hall and Lyman that when they truly dove down into this, they saw common commensal organisms that were actually pathogenic. And I know you see this too in your practice. And then if we look at this second bullet point here, skin residing pathogens, or what is found on the skin, can actually be contaminators because they really weren't in the bloodstream. We picked them up on the skin, and you can see the occurrence of that there. So given this data, clinicians attempting to differentiate true infections from simply contaminated blood cultures, we absolutely cannot rely solely on the identity of the organism. So we're going to turn this over back to Barb and look at the problems with blood culture contamination. Barb?
Thanks, Tammy. Thank you, Tammy. So we know that sepsis is the number one reason why our patients die and get readmitted to our hospitals. And it's really important to just reflect on the fact that blood cultures in general are not the greatest tests. And we know that because that's why we have to do them in multiple ways. Think about it. There aren't many other things that we screen a patient for that we have to do multiple times to make sure it's right. And the reason for that, I'll explain in detail, is because of the high degree and the high probability that the specimens get contaminated. So let me put this in perspective. So first of all, when we think about blood culture collection, when blood cultures are collected, about 8% of them end up being positive. So that means 92% of them are negative. And Tammy just described all the reasons why that can be. And now if we just assume a 3% contamination rate, and I'm using this 3% contamination rate because traditionally this has been the rate that many people have accepted as being okay. We now know better, but traditionally, let's just say 3%. So what that means is that we use a 8% or positive with a 3% contamination rate. On the right-hand side of the screen, you can see that about 60% will be true positive, but 40% will be false positive. So when we think about it, almost half of the time, the test result will not be accurate. And let's just face it, there's nothing good about that for the patient, for sure. So Oki and colleagues, they've studied, again, I'm excited to see a lot of publications coming this way. This was recently published in our journal in AGIC. And what it demonstrated was that they looked at the impact that COVID had on their blood culture contamination rate. And first of all, they noticed that patients rarely came into the hospital with bacterial infections. But if they did develop an infection, it occurred, after hospitalization. So it was a hospital onset infection. And their conclusion was that we really needed to find safe and effective ways to get blood cultures of not just COVID patients, but all patients. And they demonstrated a profound increase. Their hospital-wide pre-COVID contamination rate was 3.7, and during COVID, it went up to 6.1, which is a 65% increase. And in their ICU, their pre-COVID rate was 5%, and during COVID, it went up to 12.5. So this is really, really important information for us to have as infection preventionists because it underscores the impact that COVID has had on not just CLABSI, but on our blood culture contamination. And what does this translate to? We know that in the early days of COVID, we were literally throwing the kitchen sink at our patients. We didn't know what we were doing. We were giving way more antibiotics than we should have. We know that only 8% of COVID patients had some kind of documented bacterial co-infection, but 72% of them had gotten antibiotics. We got a little better as time went on, but in the really early days, we were given just tons of antibiotics. So how does this translate to the clinician, and what kind of dilemma does it pose for the clinician? And Tammy's going to run us through this.
Thanks, Barb. And what we were just talking about with coag-negative staph is typically what we see here, this clinical decision dilemma, this conundrum that it puts our ID physicians in. Because when we spoke to coag-negative staph as our most common contaminator, it's one of our top 3 causes of true bacteremia too. So if we look at the stats behind this, if you and I walk into an ED with a high fever, right, no comorbidities, no issues going on, and we do have a true bacteremia, 15% of the time, that's going to be caused by coag-negative staph. Now, if we look at the patient population where we have comorbidities and an indwelling medical device, such as a CVC, when we have a true bacteremia in those patients, it's 38% of the time that is caused by coag-negative staph. So you can see the conundrum that this causes for our treating physicians. It's like, oh, it's probably a contamination. We want to throw it out the window. But because we know these stats, we literally can't, because we know that if we don't treat it, our patient will end up dying. We have to treat these organisms once in the bloodstream. So you can see this conundrum that it causes when we don't have an accurate blood culture. And I'm going to turn it back to Barb to talk about the manifestation then in the patient.
Yeah, so this is really what the story is all about. We know that when a patient is diagnosed as having bacteria in their blood, but they don't really have it, we know for sure they're likely going to receive antibiotics that are not needed. And we all know too well that antibiotics are the primary drivers of antibiotic resistance and the primary drivers of C. diff. We also know that antibiotics are not exactly kind to our kidneys, so we can have patients with severe kidney damage as a result of antibiotics that they don't need. And we also know that a false positive blood culture will actually lead to an extended length of stay. So not only is that a problem for patients that are now potentially exposed to lots of other bad things, not just infections, but skin injuries and falls with injury and all kinds of other stuff. But we also know that, especially we've learned in the last year, how so many of our hospitals just don't have any beds because they're full of patients. And having a patient taking up a bed that could be used for somebody else is not a good thing. And then the final impact is that if a patient does have a false positive blood culture and they have a central line, then they can potentially be diagnosed with a false positive CLABSI. And we know that can end up impacting the patient. The patient may have their catheter removed and then replaced, so that's an additional invasive procedure. And we also know that it impacts us as infection preventionists, because then we have the requirement to report the event, which is quite frankly heartbreaking when we know that it probably wasn't real to begin with. So Tammy's going to take us through the next couple of slides and tell us a little bit more about blood culture contamination and what we know about false positive CLABSI incidents.
Thanks. So if we look to the definition in the literature about what is a false positive CLABSI, it is meaning that it's defined as meeting the NHSN surveillance definition of a CLABSI, but we really find no clinical manifestation of bacteremia or fungemia in our patients. So we did the culture because we were suspicious of something, right? And we can have patients with a fever of unknown etiology or in an inflammatory process or a neurogenic fever. And so we'll go ahead and take the culture. And then what happens is that usually we pick up a non-common commensal organism like VRE or Candida on the skin during that peripheral venipuncture for our blood culture collection. And then that, I want to clearly differentiate between an unnecessarily reported CLABSI. And that is when we have a primary infection at another site, but a culture was not obtained from that primary site. So unfortunately, when this happens, we know that the surveillance definition always trumps the clinical definition. And so even though we really don't think this is a true CLABSI, we have to go ahead and end up reporting it. And if we look right to LCBI number 1, the CLABSI surveillance definition for non-common commensal organisms, it's that our patient of any age has that recognized bacterial or fungal pathogen not included on the NHSN common commensal list, and the organism identified was not present or related to an infection at another site. And so again, where hospitals usually find this happening is they have those one bottle VREs or MRSA, those non-common commensal organisms that meet the definition, but we're really not seeing clinical manifestation in our patient. But since it has to be reported as a CLABSI, we go ahead and do that. And Barb's going to talk about the 3 pieces of literature where we find this information.
Yeah, I mean, Tammy, just to underscore your comment, I think this is what's so important for us as infection preventionists to recognize is that we have to use certain definitions, and they are surveillance definitions. And when something meets the surveillance definition, we don't have a choice. We have to report it because that's the way it is. That's the expectation. And when we better understand how to prevent these organisms that might be on the skin but not in the bloodstream, how do we keep them from getting into the blood culture bottle? That's where we're going to see a lot of improvement and a lot of harm avoided. So yeah, this is just a thumbnails of 3 papers so far. And again, I'm really, really excited to see so much great literature coming our way, especially in our journal. That demonstrates that organisms such as Tammy mentioned, Candida, MRSA, VRE, and Tammy's got an interesting story about lactobacillus in a moment, that they can be on the skin and they can be a contaminant rather than an actual true infection. So Tammy, tell your next story, because this one I think is really, really interesting.
I think it's interesting, and it was definitely an outlier, but I've seen it in the literature now 3 times, so it's not as much of an outlier as I thought it was. But unfortunately, this patient was having probiotic administration via their oral gastric tube. And what happened from this probiotic administration is that they broke open the capsule, right, and these organisms aerosolized and evidently landed on the patient's skin. And what happened when they did the peripheral stick on the blood culture of the central line patient is they picked up the lactobacillus from the skin, not within the patient's bloodstream, and they had to report this as a true positive CLABSI when in fact it was a false positive CLABSI picked up on the patient's skin. And they actually speciated this for identification, and it matched the probiotic capsule exactly, so then they determined that it was, but again, it had to be reported. So very unfortunate then. And when we looked at 2 more studies by Boyce, it was really interesting when they back and did a survey of all the CLABSIs that they reported. This first study by Boyce reported that 30% of those reported CLABSIs were suspected to represent blood culture contamination. And then when we looked to a study by Schumann, he went back and analyzed all the CLABSIs reported within their institution, and he reported that 45% of the CLABSIs that they reported most likely represented contaminated blood cultures rather than true CLABSIs. And these numbers really match what hospitals tell us. Anywhere from 30 to 50% of what they're reporting in their CLABSIs are actually these false positives, where we really don't have any manifestation of the disease in these patients. And yet we have to go on and treat these patients because we don't want to take the chance. And that's the really downside of this for our patient population. So not only do we possibly take a hit financially, but then these patients endure another 7 to 10 to 12 days of antifungal or antibiotic because we just simply can't take the chance on this already high-risk patient. So Barb.
So I know many of you are very familiar with Bob Garcia, who has contributed so much to our infection prevention literature. And this was a paper that I found of great interest. Bob conducted a survey of infection prevention leads throughout the hospital, and he actually gathered data from 90 different infection preventionists from 90 different hospitals. And what he identified is that 60% of them believed that they had reported a CLABSI that was actually a false positive, but it met the NHSN definition, so they had to. So this just underscores, and this was published in 2018, so we have known this for a while, but Tammy's great examples further just illustrate the significance of this problem. And Tammy's going to take a few more slides, and then we'll continue the discussion about another topic. But Tammy, it's all yours.
Thanks, Barb. And so we've been hammering on about these non-common commensal organisms and how they're causing typically these false positive CLABSIs. But I really wanted to also share that we do have hospitals share with us that, yes, they do also have coag-negative staff typically coming through, and they truly believe it is a false positive CLABSI, even though the patient had a sign and symptom and they picked it up in 2 sets. So most often where we see this occurring is when we're doing that big no-no, right? We're drawing 4 bottles, calling it 2 sets, but we've only poked the patient once. And so what happens is we transfer a cross-contamination of that organism that we picked up from the skin across all 4 bottles. And that's how this can usually occur. And then we know, like we've discussed already, patients have fevers for other reasons other than having an infectious presence, right? We can have a neurogenic fever. We can have just a fever as a result of inflammatory process. So again, this can happen, but please make sure that the correct practice is happening where we're doing 1 stick per blood culture set so that this does not occur. And so Barb's going to share really the economic impact of what this happens, when this happens, what the impact is for our organizations, and really help us present a business case, because we know it's very, very difficult to get help on prevention. Barb.
So I'm actually going to set Tammy up because we decided that Tammy was better at math, but I'm going to set us up for discussion and turn it back to Tammy. So we know that the hospitals that report healthcare-associated conditions to NHSN, we know that there are 3 of them, CLABSI, C. diff, and MRSA bloodstream infections, that are significantly impacted by blood culture contamination. So we know then NHSN reports the hacks to CMS, and this impacts how much money our hospitals either receive or how much money our hospitals are penalized for. And why this is so important for infection preventionists, and I really want to underscore this, is we have to be able to find our voices and build our business case. And when we can identify that our hospital is getting penalized financially for a preventable event, then it's in our best interest and our patients' best interest to find ways to tell the story, to demonstrate that we are revenue producing. Infection preventionists are revenue producing. We find ways to save the hospital money and to make the hospital money by preventing harm. So I want to set this up, and then Tammy's going to run us through some real detailed numbers.
Thank you, Barb. So if we look across the United States to short-term hospitals in acute care, so we're not talking about LTACs, and we look to their CMS percent of payment, it is typically about 32%. So if you look between Medicare and Medicaid, when we look to hospital income, about 32% of that comes from CMS. So if we had a hospital that has $800 million in income, their portion from CMS then would be about $257 million. So if we look at a potential CMS penalty of just 1%, the impact is $2.57 million, right? So incredible impact from what we think should be a very small impact. And let's break this down on how this occurs. So that we just looked to the hack penalty impact of 1%. But really, we can have up to a 6% penalty if we got the maximum penalty in all of these areas. And how these are related to hack is what we'll explain here. So the first thing that happens with a hack then is no payment from the day of diagnosis of the hack to day of discharge. And you can see here is AHRQ's most recent numbers of what these disease processes cost the hospital to treat. And then that second block there is the hack payment. And that can be up to 1%. We got to buy on this, right? It was supposed to be up to 2% as of 2020, but the government had mercy on us and they kept it at 1%. So that was the good news. So, and then if we look to readmissions and understand how that's related to a hack, we can have a penalty up to 3% of our entire annual reimbursement. And we understand that patients that have a hack have a 42% chance of a 30-day readmission. So, and then the last category that we look to is value-based purchasing, where all of this comes together and we take that money in the beginning and that goes into a fund. And this is net neutral for CMS, right? They don't take any of that money. It's all held and then redistributed to the top quartile of hospitals. So this is where quality really, really pays for us, is that we can not only earn our money back that went into that bucket, but we can earn competing hospitals that were in the lower 75, we can earn their portion of money too. So as you can see, a goal of 0 blood culture contaminations can really help prevent up to what could be a total of 6% CMS penalty from your annual revenue. So as we look at our current solutions and their limitations, Barb is going to walk us through evidence-based practices on the next slide of really how we should get this right and get to as close to 0 as possible.
So there's a lot of stuff on this slide. Yes, hello.
We can hear you.
Thank you. There are a lot of evidence-based solutions on this slide, and that's intentional because it's really the intent is to showcase that we're doing a lot of things that are designed to prevent our blood cultures from getting contaminated. Just to start, drawing blood cultures from a patient, we have to be very mindful of the fact that we should only be drawing blood cultures on patients who have a high pretest probability, people that are highly likely to have bacteria in their blood. And so patient selection is really important. It's not that uncommon for me to hear about hospitals that have practices where even patients that are end of life comfort care, where blood cultures are drawn in the last day of life, and end up growing something. And the patient, again, we should be drawing blood cultures when they're either going to guide our practices or confirm an infection, but otherwise not to do it. We know skin infection is extraordinarily important, and I'll get into that in more details in a moment. We know that blood culture tops are not routinely cleaned with alcohol wipes, and they need to be. We know that there's different camps on whether or not blood cultures can and should be drawn through central lines, but I know many hospitals have shifted from just not doing it, from not using lines directly from a central line. Tammy underscored the importance of having 2 sets. Volume, super important, because if we underfill the bottles or overfill, that can cause problems. Standardized kits are great because it keeps people from having to go around and gather stuff, go on those little scavenger hunts. We know that dedicated teams, I'll demonstrate that in a moment, can have a positive impact. We know that giving surveillance and feedback, I know of some hospitals that literally give individual feedback to phlebotomists to let them know what their blood culture contamination rate is. Multidisciplinary teams have certainly the team approach, people that have cultures where people feel safe speaking up can impact improvement. And then the final item on this list is something that may be new to some listeners, is using an initial specimen diversion device to pull away the part of blood that is most likely to be contaminated and not let that blood get into the blood culture bottle. And I'll explain that a little bit better in just a moment. So something as an infection preventionist that I wish I had a nickel for every time somebody would say, well, let's just have another in-service and that'll fix everything. Well, we know education is important, and I'm not suggesting that it's not. It's very important, but we also know that education alone often does not solve our problems, and a lot of our harm avoidance needs to be engineered out of us as human beings. So engineering controls, devices that keep us from doing the wrong thing and enable us to do the right thing. So a forcing function, making it not possible to do something that's not ideal or optimal. So it's really about, yes, education is important, but there's more to it than that. Now, I'm going to run us through this slide step by step, because this is something that I think is probably one of the most important messages that I'm going to be making today. So again, we know that training and education is important, but alone doesn't solve the problem. And I really want to just say that very often contamination is sometimes considered to be somebody's fault. Oh, well, the contamination, and well, the lab must have dribbled something on the plate and they messed up, or, oh, this person isn't doing a good job. And it's really not about a person's fault. And let me describe what I mean by that. So on the left, we speak about human factors. So if somebody has to get a lot of stuff and put things together, like typically you may have to do to draw a blood culture, there's a great risk of skin contamination, touch contamination, and that alone can make it difficult to interpret the results. The second piece is, we have a lot of attention and we speak a lot about cleaning the skin. So cleaning the skin, we know skin is got bacteria on it. Tammy described that in detail. We know that we try to minimize the amount of bacteria on skin, but there's no way we can sterilize it. It's just not possible. And we also know that a lot of bacteria live underneath the layer of the skin. So therein lies a lot of the problem. But where it gets really, really interesting to me is that, okay, so we've cleaned the skin as best as we can, but then we take a needle, a hollow bore needle, and we stick it through the skin to underneath the skin, into the vessel, into the vein to get the blood. And what happens, and you can visualize this, is what happens, it's a hollow bore needle. So skin fragments and the skin plug and all kinds of stuff gets into that needle and then gets deposited into the blood culture bottle. And it's all that crud, or all those critters that we get in the very early part of the blood draw that confounds the diagnosis, because that's where all the contaminants are. And so if we think about it differently and think about finding a way, and there is a way, and I'll describe that in a moment, to be able to take that first 1.5 to 2 milliliters of blood, and that's been studied. This isn't an arbitrary amount of blood. It's been studied that this is how much we need to pull away to get rid of that early crud, that will produce a much more pure and much more accurate blood culture results, which is always going to be better for the patient. So let's move on to the end game for false positive CLABSIs. Is there an end in sight, and what would it look like? So this is my opportunity to introduce the device that Tammy and I are going to share with you. It is currently the only FDA 510 cleared device that has an indication to reduce blood culture contamination. And I've already explained, but I'll just mention it again. It's designed to pull away 1.5 to 2 milliliters of blood, which is the studied amount that is demonstrated to be necessary in order to pull away the crud. So this is the device, and I'm going to walk you through the components. First of all, it comes pre-assembled, so it's not like shopping at IKEA and having to assemble your product. It's all packaged together, so that minimizes or virtually eliminates the touch contamination. So the blood goes directly from the vein into the bottle. It's a closed system. And let me just kind of talk you through this. So once the needle is in the patient's vein, the person who is doing the phlebotomy is gently pressing on the little wings to squeeze it gently. And what that does is it creates some negative pressure. It's a user controlled, so it's a gentle negative pressure diversion, which is extraordinarily useful, especially in a patient who's got low blood pressure because they're in the early phase or mid phase or late phase of sepsis. So what it does is it pulls the blood out of the patient, and then it sequesters that 1.5 to 2 milliliters of blood. Again, that's where all the crud is. That's where all the stuff that we don't want to go into the blood culture. And what happens is that it's not until there's at least 1.5 milliliters of blood in that diversion chamber that the new second blood flow path opens up and then allows the true, accurate blood that's in the patient to go into the blood culture bottle. And the additional thing, which I think is really important, and I, as a nurse, I can say this, nurses, we are really good at finding ways to get things done quicker. And so if there was a way for us to hurry this along and say, well, I got a couple of drops of blood in this diversion channel, I'm just going to chamber, I'm just going to go for it, it won't let you do that. It does not allow you to bypass the diversion. So it's really important, again, to remember that the diversion volume has been studied and has been endorsed by the Emergency Nurses Association and the Infusion Nurses Society, INS, have both established recommendations or guidelines for the diversion volume. The ENA is 1 to 2 milliliters and INS is 1.5 milliliters or more. And it's proposed, and we're expected that we will be getting more and more guidance from a CLSI stating that 1 milliliter of diversion volume. Again, this is what's been studied. This is what the evidence shows us is necessary for us to pull away the amount of blood that is most likely to be contaminated. So I'm going to run us through, we don't have time to share all the evidence, but Tammy and I are going to pull out a couple of studies that are probably most important for us to showcase today. This is just a showcase of, currently there are 6 peer-reviewed published studies. If you don't have access to these studies, there will be a link to an email at the end of this presentation. You'll be able to request anything that you're seeing today that you don't have access to, you can request, and we'll be sure to get them to you. But the first study that I'd like to share with you is the Dr. Mark Rupp's study that was published in Clinical Infectious Diseases. And just to showcase this is what Dr. Rupp and colleagues did is they wanted to test out this diversion device, SteriPath device. And so they had phlebotomists trained, they're trained phlebotomists. And what they did is they had the phlebotomist draw the 2 blood cultures from the same patient, one from one arm, one from the other. One arm was just standard practice, standard technique. The other was the same standard technique with the addition of the device. So it was the patient basically served as their own control. So it's the same patient, same skin flora, and the same phlebotomist. So where they started at baseline with just pre-intervention best practices is their blood culture contamination rate was 2.6%, which was probably better than many other places, but it's still, you'll see in a moment, not what our goals should be. So that was kind of where they were before they did the study. Then for 12 months, their intervention period is the phlebotomist drew 2 blood cultures from the same patient. So using best practices, they were able to reduce their rate to 1.8%. And a lot of this, may have been Hawthorne effect. People were being really focused. They knew they were being observed. People were really focused on the details. But with the same patients and the same phlebotomists, when they used the SteriPath device, they were able to reduce their blood culture contamination rate to 0.2%. So they had a profound reduction in their blood culture contamination. And equally important is there was no change in true bacteremia detection. So the positive predictive value remained very high at 97%. So this suggests very strongly that the people were important, but the device was what made the difference. And I can show in a moment what I mean by this. So imagine what happens when you take the device away, and this is what the researchers wanted to do. They decided, well, we've gotten our blood culture contamination rate down pretty low. Let's see what happens if we take the intervention away. Well, as you can see with that arrow pointing upward is that their post-intervention, taking away the device, they ended up elevating their blood culture contamination rate to 2.8%, which was higher than it was at baseline. So what this demonstrates to me is that when you engineer out the problem, even with the best technique and the best people, that is what makes the difference. So I think this is a really profound study, really well done, and then Tammy's going to walk us through Dr. Tompkins' work at Stanford.
Thank you, Barb, for that. Great review on those studies, and this is an exciting and really significant study that has been done at Stanford Healthcare. And what they did was they brought SteriPath in to divert that initial volume of blood when they were taking blood cultures. This was done hospital-wide by the phlebotomy team. And over 11,202 blood cultures that utilized SteriPath, they were able to get a rate of 0 blood culture contaminations, which is really, really significant for our patients. And when SteriPath was not used, when standard methodology was used, over 4,700 blood cultures, their rate was 2.3%. So now I want you to direct your focus to the box below that and look at what happened to their false positive CLABSIs. When SteriPath was utilized, they only had one occurrence of 1 bottle of VRE come through in that entire time period. But when SteriPath was not utilized, and they used standard methodology, they had 12 false positive CLABSIs during that same time period. So you can see in this hallmark study the incredible effect of the diversion device SteriPath, not only on their blood culture contamination, but on really mitigating almost down to 0, but 1, those false positive CLABSIs. And if you're really astute and you're looking at this and going, wait a minute, why did they have 0 blood culture contaminations, but they had 1 false positive CLABSI with SteriPath? And the reality behind that is that what tells us what is a blood culture contamination, that number and that rate is determined by our common commensal organisms that we pick up. So different classification of organisms. Remember, when we get those false positive CLABSIs, those are typically caused by our non-common commensal organisms picked up in 1 bottle, such as VRE or Candida. Now, look at one more study for you, which was a cost study. And that really shows us just 2 studies that were done a month apart, and you can see the very, very similar outcome of that, of $4,700 and $4,800 for the cost of a blood culture contamination. And Barb did a fantastic job showing us previously really why we have to present this business case to our hospitals. There were 7 previous studies done on the cost of blood culture contamination prior to SteriPath being utilized in any hospital, and those also tell us the rate range was around $4,000. So when we move to the next slide, we want to really look at what happens here, the end game for false positive blood culture contamination and false positive CLABSIs. We understand that SteriPath not only diverts and sequesters our common commensal organisms, which cause our blood culture contamination, but it also diverts and sequesters those non-common commensal indwelling organisms, right, that are causing our false positive CLABSIs. So again, those rates aren't equal to each other, and some hospitals will tell us, well, we don't have any false positive CLABSIs because we have a really low blood culture contamination rate. But again, those are not equal. 2 different types of organisms are causing those rates. And so just be assured that with that 97 positive predictive value that SteriPath has, it reduces both our blood culture contamination and our false positive CLABSIs, and truly, truly looks to optimize our patient outcomes and our CMS reimbursement. And we're going to pop back to a slide to have Barb share with you just a plethora of data that is out there so that you feel confident in what has been accomplished for patients. Barb.
I'll do this quickly because I know we want to leave time for a couple of questions, but this just showcases the studies that have been done on the SteriPath technology. In the green bar, that is just to showcase that the blood culture contamination rates in all of these studies was 1% or less. And then in the blue bar, it demonstrates that each study group achieved somewhere between a 75 and a 100% reduction in blood culture contamination. And one facility was able to demonstrate a significant reduction in their vancomycin days of therapy, and ultimately demonstrate and underscores the financial impact that Tammy just described. So let's move back over. I know that Tashi's hopefully got some questions for us.
I do have some questions for you guys. So as a reminder to all our listeners, please select the Q&A tab to ask a question. Simply type it into the chat box and be sure to select submit your question. The first question that we have is, what specific clues would alert me that we may have a false positive CLABSI?
If I can answer that, what we learn from hospitals is it is typically those 1 bottles that pop positive. So out of 4 bottles that were taken over 2 different sets from 2 different sites, we only have 1 bottle popping positive with typically a VRE or Candida, those non-common commensal organisms. And then looking at the patient, were they symptomatic? Did other lab tests and clinical surveillance show us that this patient was asymptomatic? And really that leads us to do a chart review within those hospitals, saying, yes, it met the definition, but really there was no clinical manifestation of disease in that patient. So again, those 1 bottles that pop positive for VRE or Candida are typically what we see.
And if I could add to that, Tammy, I think one of the things that we've noticed is I've heard from a lot of colleagues that they did see an uptick in candidemia blood cultures during COVID. And any clinician knows if somebody's got a fungal infection in their bloodstream, they are super sick. And so going back and doing the chart review, as Tammy mentioned, is a way to say whether or not, well, this patient probably didn't really have Candida in their bloodstream.
Great. So we have time for just one more question. What actions are usually taken by hospitals to follow up and confirm that there is a false positive CLABSI?
Yeah, I think it's just what we just talked about is they'll see that 1 bottle pop positive, and then they'll go ahead and do that chart review on that patient and really pull the other labs, right? And was there an absence or presence of data? And what were the clinical manifestations of disease in that patient? Were they there or weren't they? And to Barb's point, our patients are truly, truly very sick when they have a candidemia or a bacteremia. And when we're not seeing that, we're very, very suspicious that they met the NHSN definition, but they truly do not have a CLABSI.
Okay, seriously, the last question. When central line infection is suspected, is the use of SteriPath recommended via the suspected line?
And I can answer that. You're asking if we should be drawing using SteriPath from each lumen of the catheter on the CVC. Was that the question?
I'm just going to repeat it, or if the submitter could clarify, that would be great. When central line infection is suspected, is the use of SteriPath recommended via the suspected line?
Yes, and so we don't have any peer-reviewed published articles that are in a major manuscript, right, in a major publication about CVC draws utilizing SteriPath. We do have some hospitals that have used it for years and have been very successful with their rates when they're drawing from central lines, but again, we don't have the data published, and we are a data-driven company.
Thank you for that. To all of our submitters of questions, we are at the top of the hour and we don't have any additional time, but please utilize info@magnolia-medical.com to submit any additional questions that you may have related to this presentation. I want to say a special thank you to our presenters, program sponsor, Medical Magnolia Technologies, and to everyone who participated in today's program. If you missed any portion of today's webinar or would like to view the presentation again, you can access it from your archive in your educational dashboard in 24 hours. An email announcement will be sent to all registrants once the on-demand viewing is available. To access any resources, please utilize the Resources tab on your educational dashboard when you launch the program. Today's program is copyright 2021 by the Association for Professionals in Infection Control and Epidemiology, with all rights reserved. This concludes today's education program. Thank you, and you may now disconnect.